Maggie, can I ask you one question real quick?
Absolutely, yes.
There's so much I missed in the chat, but I just wanted to elevate something, if it's okay. Yeah, Megan
Yes.
Gerber said, "This PCP feels so hurt. It is insane, but we go on because we care." And I think there's so much in that. It totally is insane, and yet it keeps going on because people, heroes like Megan and like all of you, whether you're a clinician or a patient, you keep persevering. You know the fundamentality of this truth that being seen and heard and being in a long-term healing relationship, despite all the barriers, or seeking long-term healing relationships that see you as a person, see you for your holism. I see Kurt Stange there. You should read his work on holism and his brilliant practical and theory of primary care that I've learned so much from. But it is about care. It's about the second word, not the first word. It's not about the primary school level. It's about the care part, and that ultimately is what gives me hope.
That's awesome. That's what gives us hope too. And thank you so much for that, Asaf. Okay, I'm going to send people into small groups, and let us know if there's any questions, and looking forward to hear what you guys talk about. Great. Okay. Great. Let's see. Let's see, Dr. Geist. Oh, there we go. Perfect. Okay. Asaf and Victor, thank you all so much. That was really incredible. Yeah, I think, well, I was doing a lot of multitasking, but lots of things to kind of resonate on. So I really appreciate it. I think there were a lot of links that were kind of shared in here, but if there are any, Asaf, that you think are particularly relevant, if you want to share them with me after the call, I'll make sure that they're included when we send out the video.
And would you share the title of the book? Someone just asked me for it that you just mentioned.
Kurt Stange.
Oh, Stange. It's actually a series of articles. I'll put a link into them. They're some of the best articles I've ever. He's an incredible. They're called the generalist approach, and he argues basically for what we're talking about. On a sort of, it's like a general theory of primary care. He's like one of the, one of the core physicists, theoretical physicists of primary care. It's wonderful to see him. I'll put a link to the article.
I'll send you back into groups.
Is Megan waiting to be assigned?
Yeah, sorry, it's being weird, but
so the onion layer questions, I'm very sorry to have asked
Oh, I gotta razz you, Victor. We have to, it can't be, we're not like on NPR here. We have to have a little humanity, a little good.
I was thinking cutting through it will make everybody cry. So I guess that's why the reference to the onion, but I guess not. It's a multi-layer thing.
Yeah.
Well,
or like in Günter Grass's famous novel, The Tin Drum, about post-war Germany, where people couldn't cry anymore, so they went to the cellars and cut onions and then just sat there, and then they could cry. I don't know, just thought
that's
about
very sad. Yeah, very sad. Maggie, there's Jane Everett trying to get through. So yeah, the goal here, Asaf, is that we're going to be able to have 3-4 things that we stand for, which are concrete and versus our general message. And Any downsides? I didn't ask you this. Any downsides of taking an approach, standing for primary care for all? I mean, are there any reasons why it could be?
There are a few. I saw a couple in the chat. Number one, was this you, Maggie, that said it? You know, one person's necessary resources is another person's loss, and people have incredible loss aversion in US healthcare and will fight to maintain their homeostatic resource flow at all costs and are very effective. It's actually not a zero-sum game because there's so much stupidity and wasted effort in the US, but it is perceived as if you invest a little more in community-based primary care, then my special urology clinics won't get the funding they need, or I might not make, as a specialist, $800,000, I might make $700,000. And though I'll leave the editorializing on that aside, that's a real thing. So you are playing with powerful astroturf and lobbying forces. Number two is probably even more fundamental, which is unnecessary exclusion. I mean, primary care is necessary and alone insufficient to the kind of healthcare systems that we want. We need specialists. We need acute care systems to be reformed and to be more humane, because people will travel through all of these systems and then come back to primary care. But primary care has sometimes felt like it's an either or it doesn't have a good integration as an advocacy movement with diabetologists and other necessary specialists. And then number three is the issue that every time, I mean, it's like not the first time people have thought about making national patient level advocacy movements for primary care. There have been very well funded ones for the American Academy of Family Physicians, and they go nowhere. So I mean, that with humility is just like studying and understanding why they go nowhere, why they can't achieve policy resonance and relevance. That's an important consideration. I would argue to you that they've been mostly a failure because they've been focused on clinicians and clinician burnout and clinician funding as opposed to patients. An advocacy movement based on people's needs, people crying out for oxygen, saying, I can't see how my healthcare experience is going to be organized and be better without better primary care. How could you let this fundamental building block of healthcare wither on the vine? That's not acceptable to me. This is a bipartisan issue. That story, there might be something there.
I'm also worried about the workforce, not burnout and all that. I'm worried about that. But there is now a generation or two or three of primary care clinicians that have been trained to be, to not be the comprehensivist, continuity, not value continuity of care. We work in teams, and they say, well, how big is your team? Oh, there's 660 of us, that sort of stuff.
Yeah, there's a trade-off between the individual dyad. This is the access versus continuity question too. Everybody wants their person, their dyad of one-to-one who walks with me all the time, and yet the just enormous explosion of need across so many different use cases of how health is created or destroyed says that there's this tension and uncomfortable trade-off that has to be made between the team and the one person who knows you super well. And that's we could have a whole other discussion on that too. There's a way through that, but it's complex. Everyone needs their person, but they also need their team.
Yeah.
And it's not always an MD. And that's another thing.
Well, that's the
Needs
that's
to
I'm
get
so
over
surprised
that part.
that's why I'm so surprised about the not surprised, but a little bit. I'm watching the stuff in the UK, which for different reasons, the the government is pushing for the NHS to pick up a lot of non-physician clinicians to provide primary care, and the physicians are up in arms. I think in part because the advertisement is meet your specialist, and it's and they don't indicate that he's not a physician. So
Yeah. And the UK is really, the primary care system is falling apart there, and I'm not being hyperbolic. You could
no.
see it in the chat where it was 10 years ago, 20 years ago, where it is now. Part of it is corporatization. Part of it is they made a huge fundamental error of essentially taking accountable care organization like entities, and it all seemed like a good idea. Don't put money into hospital-based accountable care organizations, put them into primary care trusts. Okay, that sounds nice in theory, but if you don't enable the primary care trust, i.e. the primary care physician organization, to have the analytics, business acumen, administrative and managerial structure to sort of be the umpires over the food fight of money between primary care, specialty care, and hospital care, it'll implode on itself, which it did, and then successive conservative governments then sucked out money from the primary care trusts and then said, oh, we're so surprised that there's capacity and burnout issues. I wonder where those came from. I thought we had it good.
The and there's the inequities of those systems. I saw the deep end problem in the Scottish people have been working on, and the Danish, I was in the Zealand region in Denmark is they're struggling with how do they get primary care into the rural area.
Totally. Same
yeah.
with Estonia, that has as good or better primary care than Denmark, very quietly. They cannot figure out what to do in the rural areas. And Estonia is like the size of Southeast Minnesota. I'm not kidding. And you're like, what do you mean? You're a million people. It's not that big. Let's go. Rural primary care is hard.
And do you see technology doing something there?
I see it. Look, it's an augmentation. When technology becomes the destination, whether it's AI or whether it's telehealth or whether it's chat functions, it fails a priori. I mean, prima facie. But when it becomes an augmentation of the fundamental relationship that you're trying to augment and build, it can be great. But we get those confused all the time. Like, there's so many people in primary care that are so worried about AI. And I tell people, look, if you want to have the robots are going to kill us conversation, I agree. I'm worried about AI. And I'm not joking. If you want to have the conversation of which part of the healthcare system could most benefit most quickly from AI, I'm going to make a very strong argument it's primary care. And you would tell me, what the hell are you saying? And I'll tell you this. What is the thing that is like killing the people on this, your primary care clinicians here, is 40 patients, 40 notes, pajama time, EHR, blah, 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 right? Okay. So what's the way into that we can do tomorrow something about? An AI documentation tool that already works, Nuance, Ambient, all this stuff. It's cutting documentation by 80 or 90%. And you don't have to believe me. This is like new data that's just out. I just signed up for an AI pilot. As long as the patient is okay with it, this is how dumb AI can actually get us to the next level, to be able to create space for relationships. We need space and money for the real stuff that matters. And like technology as an augmentation can do that. But it's not the destination. Like primary care will probably be the last part of medicine where a clinician will be totally like replaced by AI.
Well, unless they change the definition of primary care, right? So if primary care becomes this sort of basic processing of people at the front end to figure out which specialists they really need, then you can see how that can, when you redefine, and like some of
people have talked about that for so long, and yet like that's the thing that AI, it might get there, but it's the worst at complex sorting with undefined numbers of variables based on dynamic human interactions that are often face to face, that, you know, the person says they're here for abdominal pain, but what they're really here is because they're depressed from domestic violence. Like AI may get there, but that's the last thing it's going to get to. What it's going to get to first is bye-bye radiologist, bye-bye dermatologist, bye-bye pathologist, because mimicking those functions is actually way easier than mimicking the complex human interpersonal dynamics. And then people say, oh yeah, but it's just a triage function. It's just like the check-in counter at a hotel. Okay, this is Michael Porter stuff.
Yeah.
The check-in counter at the hotel assumes that you know the hotel you want to go to and the room you want. If you're a person, it's like going to the hotel factory line in Disney World. You don't even know what hotel you're at. You have an undefined, unexplained set of symptoms that may or may not be serious, and you need some guide over time with you. You don't even know what hotel you're going at. You need someone to kind of work with you and see you for who you are and use their brain and have the time to do that and the empathy to do that. That's that function, that sorting function to specialty care and back. Like, people don't know they have, you know, a serious condition for the most part, so they don't easily sort themselves. So I'm still bullish on the need and the utility of kind of comprehensive primary care.
Yeah, no, I think we're on the same page there for sure. The in my space, healthcare is being redefined as a problem of information. And of course, as a result of that, then information technology tools are going to be care tools. And the distinction between care and information management or information sorting is being blurred, I think, on purpose to create value in investing in information technology versus in care. But yeah, I think that's part of the advocacy we have to do. Is part of the, you know, the industrialization, now the information on top of that, you know, creates distorts what healthcare is about. And so, well, this conversation has been about what it truly should be. And then the problem, of course, of the undercared, right? So the problem of the patient with undefined medical symptoms, undefined, you know, undiagnosed or undiagnosable conditions and untreatable conditions, you know, like your long COVIDs and all these other things. Throw them into specialty care, and you just have a machine for producing useless services and tests and treatments with no hope of making any difference. So unfortunately, you throw them into primary care, and they, you know, in my space, there's no continuity, there's no relationship, there's no compassion, there's just referral.
Right. It's kind of, you know, like the I Love Lucy chocolate factory thing, where, you know, it's just the more and more chocolate going down the conveyor belt, and it's, you know, I don't know if you've ever seen that episode, but it's.
I'm Peruvian, man. I don't know what the hell.
All right, I'm gonna here. This is important, sort of American cultural artifacts.
Very true.